Stress, as you know, is the core of all mental health breakdown. If you get stressed out too much, if you've got any condition whatsoever, underlying condition, put lots of stress in there and you'll see that condition emerge. Yeah. That's just a simple fact. So I'm very, very careful about stress. So I know exactly what it looks like and feels for me. And if it starts to emerge, and it was a few weeks ago, I was beginning to notice I'm feeling fed up at work and a bit depressed, and beginnings of stress at work, and I just sort of knocked it on the head and I started talking to people and I slowed down a little bit.
Hello, I'm Dr. Sheri Jacobson, and this is TherapyLab, a podcast dedicated to therapy, thought, and the art of mental well-being. In this episode, we are joined by Noel McDermott, psychotherapist and mental health consultancy CEO, to talk about his life and work. Hello, Noel.
Hi, how are you doing?
Very good, thank you.
Good.
Thank you so much for joining us today.
It's my pleasure, really. Thanks for inviting me in. It's I've sort of been a great fan of yours for a long time, so it's nice to be on your couch and talking to you about work.
That's very, very kind. Thank you. How are you doing?
Okay, I was saying before we started, it's been full on. It's been 7 days a week for a few weeks, so which is okay. I'm okay with that, but I'm just aware of it, and thinking about self-care and stuff like that. And so I have a cut-off point today where I was going to say no more. Not going to worry about all the things that haven't been done.
Especially as it's a Sunday.
It's a Sunday. It is. That's right. But I'm not complaining. I've got a great life out of what I do, and I enjoy what I do.
What's keeping you busy?
It is. Which is great, and I'm genuinely not complaining about that.
And what is occupying you? What are you up to?
Well, I've got a number of companies which all work in a similar way, but in slightly different areas. So the three areas of work are mental health, addiction, and workplace mental health. And what we do, I'll provide complex care packages within that to help people stabilise in those environments to avoid having to go into hospital or rehab. Okay. So we prevent hospitalization or rehab admission.
Tell us a little bit about how they work and how people access the services.
Okay, so we have specialist teams of people, multidisciplinary teams. You just give us a call or email us, and I'm sure you'll put the details of how to contact us on. I won't bore people with that. And you'll get me, and we'll arrange an assessment, and then we'll find a team of people that works specially with you and your specific issues, and we will develop a care plan. Which is very detailed and complex, and you'll be at the centre of it and you'll help us build it. We'll bring in all the professionals that you need to meet those needs, whether they be severe and enduring mental health needs or complex and chronic addiction needs, or you're having a breakdown at work and you want some help to stop that and get back on track. Whatever the issues are, we will source all the professionals that you need, work out the plan for that and manage that plan with you so that you stabilise in situ. Don't need to have an admission into a rehab or a hospital, and you get well where you are. And the evidence is if you do it that way, it's much more effective, and the long-term results are better. Less chance of you relapsing at some point in the future, and you learn the practical and emotional skills that you need to manage your condition in situ with the everyday stresses that you would have. So you come out with much more realistic sort of management strategies for long-term stabilisation.
What are the more common presenting issues, if there are any?
So it's been quite a range because we can work with very complex issues. So I've had a range of presenting issues from bipolar to psychotic illnesses to depression, anxiety to addiction issues, as I said, burnout. Stress, and then stuff which maybe you're not the identified patient isn't the person who contacts us, but maybe a family member. So any of those conditions within a family member, and you need help within the whole family system to help you manage sort of somebody's long-term or chronic conditions.
And where does therapy fit in that? Is that a significant part, or is it just...
Yeah, it's crucial. I mean, I come at it as a therapist, so I think what makes us unique is that I come with a systems therapeutic approach. So I look at the team that we build as a system, which mirrors and looks at the issues within the system that we're treating. So I never see an individual with a psychological problem. I see that person plus all the connections.
All the people in their lives and their
all the people
situation.
in their lives that are affected by that. And all those people, all those connections are their system. And it's that system that we're looking at. And I think as a therapist, that's what I bring, is a sort of unique understanding of that systems approach. And then when we work the teams and the solutions, including the various therapies that we use and the various modalities, they all fit into a systemic understanding. And we'll deal with, so when we deal with people, it's generally not just the individual. There may be other members of their family or their team or their staff, depending on the situation. You know, PA might be brought into the work. And all of those will get individualised support and be thought about in the context of trying to make a system that works very well.
Yeah. What other practitioners besides talking therapists might be involved?
We have psychiatrists, physiotherapists, we have occupational therapists, I have peer support workers, people who are not qualified but we supervise and support who can help access peer-to-peer support groups and do general sort of getting out and about and reintegration work, as well as psychotherapists and a whole range of psychotherapists. I mean, there's many different types, as you know, these days. There isn't just one thing called psychotherapy. It's very nicely diversified now. I think we've grown up in many ways and become much more sort of, we can have specific psychotherapies for specific conditions now, which is not something I would have thought was possible when I first started training 30 years ago. It wouldn't have imagined that, but now we've got, you know, DBT, which deals with very specific, as well as being a broad psychotherapy. It also deals with, you know, specific issues around personality disorder, etc. And it's amazing stuff. I think it's really come on from the days when I trained and we were talking about transference and counter-transference, and that's all you could do.
It has evolved a lot. Tell us about, so you started training 30 years ago?
Just about now, yeah. It was.
And what led you into that?
Well, I was, I started off in the arts. I was an actor and a community arts worker and a director. And I did a lot of that. I didn't do very well as an undergraduate. I had a lot of issues myself, having grown up in quite a dysfunctional family. So violence and addiction and various things going on. So I was quite a vulnerable young person and young man. But the place that was safe for me, I guess, was theatre and the arts. And I could be quite wacky and it was okay. You were sort of allowed to be in the arts world. It was quite bohemian. So the fact that I was slightly odd in my functioning didn't seem to matter, you know. So I worked in the arts and I got involved in working with people who were coming out of long-term institutional care. They were using arts teams to work with people who'd been in long-term hospital care, and particularly people who may have been non-verbal or pre-verbal, maybe learning disabilities or things like that. And they were using arts workers because I think they just didn't know what else to do, is the truth. So I started doing that, and I was working on one particular hospital closure program. It was a hospital called South Ockenden, which was a very famous one of these huge bins that people were thrown into as babies and left for the rest of their lives, and you would die there and stuff like that. You know, it was one of those things. And they've been closing that down over about 15 years, and we were right at the end of it. And there was a cohort of people who were particularly challenging and difficult and presented violence and self-harm and various things. So we're sort of quite high risk and quite a challenge to services. I ran out of skills, is the truth. And I was been working in multidisciplinary settings at that point. And the joy of multidisciplinary settings is you get to meet people from different professional sort of backgrounds and you learn from them. And I met a lot of therapists who, quite a few of whom I thought, I'm not quite sure I'm into what you're saying, but there were a cohort that were very sensible and very grounded, and I guess just knew what they were talking about. That's what I think now. They really knew their stuff and were able to have a conversation that didn't make you feel stupid and all that sort of stuff. And one in particular, I thought, you're making a lot of sense, and I'm interested in knowing more. So I phoned up the college where they trained, and they said, oh, come along, we've got an open day, and why don't you join us? And I did, and it wasn't an open day, I didn't know, it was an interview. Lots of people had worked very hard to get a place on that day, but they just gave it to me. And I had no idea, and did the whole day, and then at the end of the day, the guy said, so why do you want to be a therapist? And I said, well, I don't. And he said, well, what are you doing here? I said, well, I just wanted to find out more about it. And okay, and bless him, he just took that in his stride, and he said, well, what have you learned? And I told him, he said, that's interesting. He said, do you want to do some more? And I went, oh, yeah. Okay, well, you've got a place. And that was it. And then I got on this course, and it just happened to be perfect for me. It was 1 year full time, so 5 days a week, very intense. And I did it, and I even got some funding for it, it was a postgrad thing. I got a grant, and I got a living grant as well, not just the fees paid.
That's but very unusual as a trainee therapist or new therapist.
Postgraduate as well. I was like, wow. But there you go. I'd done a lot of work in my borough, so I think they thought that I'd sort of done enough work to deserve it. But I got it. I got on, and in hindsight, it was the best accident that's ever happened to me.
And then how soon after did you start to practice?
They told me not to straight away. I mean, they were very clear about this. You don't practice as soon as you finish training. You're not ready. Take some time off. So I did. And I took time off about a year, in which I did some care work. And I worked with guys living with HIV and that, in those days, this is a long time ago, if you were living with HIV, you were still quite ill. And you needed, it's unlike today, I mean, if you're living with HIV now, you don't even notice. But in those days, you were still quite ill. So there was a lot of home care stuff, and I was ironing shirts and cooking food for these guys, and listening to Women's Hour while I was ironing shirts. It was great. I really enjoyed it. I just really enjoyed not having to think about therapy at all. I'd had enough of it. And so that was really nice. And then about a year later, I went with my partner at the time up to Edinburgh. And there just happened to be a hospital they were closing. They just happened to have an arts team, and I joined them and said I wanted to start my practice. It was the arts therapies department. And they said, sure, we're not going to pay you as a therapist, but you're welcome to be one if you want. And so I joined them, and it was a similar cohort to the Ockenden group. So I was very comfortable. I knew what I was doing, and actually became quite a resource, I think, because I'd been there and done it. And so there are particular stresses and strains in that work. And that's where I started. And then I moved into, from that, I had a fantastic, it was amazing work. And then it got better. They wanted me to start a forensic project, which I don't know if people know, but forensic means pertaining to the criminal justice system. So I was working with people who had done some pretty horrific stuff and had been through some pretty horrific stuff, but were sent to hospital rather than prison for treatment. And it was an extraordinary place to learn how to be a therapist. Very, very amazing environment, working with some cream of the cream people. I was really, really lucky and very honoured. And learnt my trade from them, working in these hospitals. And the stakes were quite high as well, because it's all about public safety. So if you're working with somebody who might be a threat to the public, you need to really be careful about what you're doing.
There's no better learning ground than complex
it was really
conditions.
And I learnt a huge amount about how you cannot do it alone. So any of that ego, omnipotence, as we might call it, stuff that you get when you first train, which we all have when we're first qualified. It's like, oh, I'm going to save the world, or my brain is huge, my skills are wonderful, and it takes a while to deflate that. But it was very quickly sort of held in place by, meeting people who were clearly far superior to me in terms of their work and their experience, but also because the stakes were so high. And you had to be very, very thoughtful about it. Yeah. But it was fantastic. I got to do some things that I thought I'd never be able to do. So I got to do, Tom Main and the slow open. Tom Main was an amazing therapist who worked at a Castle Hospital, which is over in West London. And he invented group processes that could counter institutionalisation. So he worked in these psychiatric wards and created what he called slow open group processes, where staff could become members of groups and would leave their ID badge at the door and then join in the group. And the idea being that institutions create institutionalisation, whereas if you can bring the non-patients in, you can counter that process and change some of the power balances. And they were doing some really amazing stuff, the Castle Hospital. And so I got to do some of that work with some great supervision. They gave me free supervision. I spent 5 years working in that trust and learning a whole lot and getting a whole lot of life. Actually longer, it was 10 years.
Wow.
Blimey.
And then what was next on the cards for you?
I came back to London and I had a small private practice as a therapist, but I had broader interests, and that was my story really. So I joined social services and I worked a lot with joint social services and health projects, working with refugees and victims of torture. Again, so I worked in Haringey.
More complexity.
More complexity. We had 1,200 families we were dealing with in Haringey, and a similar number of unaccompanied young people who and so on, and not just that complexity, the psychological complexity, and learning stuff about torture, which is horrific. It is extraordinary, the things that people will do to other people. And do it consciously and on purpose is quite extraordinary. But also what's extraudinary is watching people heal from that. And it's mind-blowing how amazing, and I might cry, but I sort of think about some of my patients then. They were heroic. I mean, they were extraordinary people who had been through unimaginable sort of stuff and yet had the courage to heal. And had the courage to do what they needed to get well. And we were, at times as professionals, we would have to shrug and I don't know what to do, let's try. And we would say, why don't we try going for a walk in that beautiful wood? The bluebells are out. I don't know if that will help. Why don't you give that a go? Because some of the stuff was just beyond comprehension. And you were working very much at the leading edge of trying to find meaning and purpose again. And that meaning and purpose became the glue around which people could then sort of bring their shattered selves together, because that core of meaning and purpose had been destroyed.
Yeah. And does much of this resonate with you? You referred back to your childhood, periods of violence. Can you talk a little bit about some of the things that you went through, to the extent to which you're okay to share?
I'm very comfortable. I you have to stop me talking about it. I hope it doesn't upset people listening as well. So, slight trigger warning, I suppose, really about it, and just look after yourselves if you're in it now. It's also, if you're in it now, you can get out of it, I promise you. I have both my parents who come from Ireland, and both of their families were involved in the armed struggle over there. So it was all provisional IRA stuff, particularly my mum's side of the family. And my grandfather was very heavily involved, very brutal man. I don't remember much about him, thankfully, just his belt buckle. That's what he liked to hit us with. So. But I have lots of those, traumatic frozen memories and all that sort of stuff, and the black and white photograph memories that you get. But thankfully, nothing else. I don't really want to remember him. I think my sisters remember more about him, and I don't envy them. But that's what my mum grew up with. And my father, something similar, but my father was also, is also an active alcoholic. So it was all complicated by that stuff with him as well. So whatever he started out as, progressively things just got worse and worse for him. And he was also very violent in the alcoholism. He was one of those people who, when he drank, he became very violent. And so there was a lot of that going on. So it was a very frightening household. to be in, and very confused boundaries, very confused identities, very confused loyalties, lots of learning that I've had to unlearn around damaging relationships and how to have relationships that are not damaging, and how I can have boundaries and how I can put my own needs first, and also lots of treatment around the trauma as well. So I had PTS symptoms for many years, and I got treatment for that. So
when was that picked up on? Like when was the earliest point at which you were receiving help for any of these psychological
not
difficulties?
Not to my 30s. And it was one of the drivers. The thing that happened was the partner I had that I moved to Edinburgh with actually took me out dancing one night and gave me a tab of ecstasy. And I took it. I wasn't much into drugs. I'm more like my father when it comes to things like that. And not the violence bit, but the alcohol bit. Anyway, she gave me this tab of ecstasy, and I had this strange feeling and this odd thing happened to my face. And I said, "Oh, what's this feeling?" She said, "Oh, that's happiness." And I went, "Oh my God, that's what people have been talking about." And I'm not really joking. It was sort of like that. And then I just thought, oh well, that's quite nice. I'd quite like more of that. And that's when I started looking at getting therapy and talking to people about this thing that I'd experienced and whether it could be replicated, and started getting help. And
how did you approach that? How did you seek out help?
Well, it was all a bit pin the tail on the donkey. You know, it was sort of asking people, have you heard of anybody? And there wasn't much internet then. It was there. It was there, but it's not like it is now, where, you know, you and I have very clear presences online, and we work at the social media stuff to give people appropriate information and help. But it was a bit sort of pin the tail on the donkey, and you just tried things out. There wasn't much of a range of people at that time as well that I could choose from. So I just started with somebody who was seemed nice. I liked him. He seemed kind, and he wasn't too frightening, and I was easily frightened, so it was quite nice. I was still very hypervigilant, and still had flashbacks and stuff like that. And I think he was a person-centered approach, and just very gentle, which was right for me at that point. And I did see somebody else who was more analytic, and I found her too frightening.
And analytic meaning, for those who people don't know, kind of more childhood roots and explorative, and
also in style, more distanced. So it didn't give me much feedback, or which doesn't work for somebody, I don't think, who's very, very anxious.
And for you, how did you feel about the two contrasting approaches?
I much preferred the guy who was a bit warmer, he was more present, he would talk about himself, and that made me feel more comfortable. And then, of course, I went and got work in this trust, and I had access to masses of support. Actually, they were really tip top in terms of encouraging all their staff to get help. And I went to see a guy there who's dead now. His name's Neville, who I saw for most of the time I was there. So a long-term relationship, and he happened to be somebody who was very well educated in therapies and had a lot of experience with people. And his style was a very mixed bag, actually. He was very much somebody who was just a pragmatist, and he worked on whatever would work. And not so much the cognitive behavioural stuff and giving homework, but in terms of his approaches, it was very eclectic. CBT wasn't huge at that time. It was coming in. But it wasn't huge. And then later on I did other therapies. As I learnt more about it, I went and did some CBT. I didn't do any EMDR, and because it hadn't really emerged, and I got stabilisation, and I processed a lot of the trauma through the CBT and through the other therapies that I'd chosen. Psychodynamic was good for me. So less analytic, more, and I think these days if I had still a need to do it, I'd probably go for something like CAT, cognitive analytic therapy, because I'm really into the psychodynamic approach personally, and it sort of I connect with it. I connect with that integration approach, but I think CAT is just a lot quicker now. and you don't have to spend a long time doing it. And I like that as well. I like people explaining things to me and just getting to the point and sort of not being too distant, not expecting me to sort of get there myself, but being helped. I sort of like the feeling of being helped. So a range of stuff. And I still see a supervisor, come therapist now, and he's been my supervisor for over 10 years. And he's a Jungian analyst, and I tease him about that a lot. And so we get on very well, but it's very interesting, that approach as well. So learning about those types of ideas has been sort of, very, very helpful. And also I'm in recovery, so I go to peer groups myself.
Tell us a little bit about that, your experiences, and also if we can talk about the addiction side, because that's something that you offer as a service as well.
Yeah. So I've been in recovery 11 years, and I suppose where I'm coming from is I see addiction, I see the sort of mental health issues and the addiction issues as primary conditions now, whereas at one time I thought one was the result of another. So, but these days I think they are primary conditions. They have crossovers and links, but they need their own forms of treatment. Those forms of treatment need to sort of work alongside each other. One of those forms of treatment, and it's not often thought of as a treatment modality, but it is peer-to-peer groups. And in the UK, principally things like SMART and 12-step, 12 tradition groups. And we're now seeing, I think, in terms of UK, in terms of mainstream mental health services, not just addiction services, but the uptake of these peer support groups. So you'll see them now in community mental health teams. They're bringing in things called recovery colleges, which are doing similar types of things, so encouraging people. You've always had it in the mental health world, so you've got things like the Richmond Fellowship, which has very much had that approach, supporting people with the condition to find solutions themselves with other people with the condition. And essentially, I suppose it works like this. If you think about an AA group, so if somebody wants to stay sober, or if somebody wants to be good at anything, the best way to become good at something is surround yourself by people already very good at it.
Yeah.
So if your plan is to be good at being sober, surround yourself by people who are good at being sober, and it'll work. And it doesn't need to be any more complicated than that, really. So that's how they work. And they're now using them for things like diabetes, other long-term physical health conditions now. They're creating these groups, the NHS. And you're seeing that within what's called the social prescribing model of care from GPs, that people rather than being sent to hospital are being sent to these groups, because what we know from this work now is that, yes, it's very good at dealing with the condition, but there are some value-added things that happen because you're becoming part of complex social groups. And one thing about these groups is, for example, addiction doesn't tend to target only one class or one gender or one race. It's pretty much an equal opportunities destroyer of lives. And so what you will find in these groups are very diverse groups of people. So you get all genders, all races, et cetera, represented, and all strata of society. And effectively what you've got is a perfect environment for neurodiversity, for the frontal lobes to just go, wow, this is great. I really want to grow, I really want to develop. And that's in many ways one of the processes that psychotherapy, as you know, engages with, is this development in the frontal lobes and neurological development, putting the brain in a strange situation so the personality has to adapt and grow in healthy ways. And that's what these groups provide.
And is that in combination with one-to-one help or instead of?
I would say it's in combination. I think the model that we tend to look at in terms of, and this would be for all mental health, chronic, complex mental health, is you have the biomedical component, you have the psychological, psychotherapeutic component, and then you have the psychosocial component, and you put all three of those in. And what we do with people is they help them think about all of those components and how they all fit together, which is where our peer workers come in, because they can help people integrate into these peer networks in a safe way. Because of course the peer networks are not regulated and they have people in them who are quite ill by by definition. So I think it's helpful at times to have somebody who can go with you, who's able to spot some of the problems and help you navigate it. So that's what we do. So those three elements come into play, and they all sort of need to be there. And then also what you then think about is then transformation, cultural transformations away from, so coming back to the systemic stuff again. What you will have found in chronic conditions is that the system that the identified patient lives in has adapted to the dysfunction and will keep the dysfunction in place. So even when somebody has stopped drinking, for example, everybody else still behaves with them in behaviour patterns around as though they are still drinking. And so they need support and education to move beyond that. And working in this way allows you to then help that system shift and change as well. And in ways where it doesn't break down. So one thing we know, for example, is that without help, about 3/4 of marriages will break down when one person goes into recovery.
Right.
Because they just don't know how to relate to each other anymore. And so if you give some help to people at that point, and it's the same with all the relationships in the system, that they may have become quite codependent and quite dysfunctional. And this is true whether it's addiction or trauma or bipolar disorder or psychotic disorder. The adaptations will have happened. So what you're working with is new adaptations to help personalities shift again and adapt to the new, healthier way of being. And that way you can help people transition into maintaining the relationships that they want to maintain, and rather than having to cut people out of their lives because they experience them as being very ill or sort of pulling them down.
Any examples, anonymous examples you can give us of people whose transformations you've witnessed from start to ending?
Really. I mean, it's what I like about what we do is we stay with people for as long as they need and as long as they want, and I really like that. And there's no dangers of institutionalization because you're not in an institution, so it's okay. And because you're using lots of different modalities and lots of different approaches, you stop the risk. So psychotherapy after 2 years can become harmful if you're not careful.
Is that right?
Yeah. So you have to be sort of thoughtful about. But because we have lots of different modalities and lots of different professionals, we can avoid those types of pitfalls. But yeah, I mean, I'm thinking of a very complex condition to treat, anorexia, particularly anorexic type B. Very difficult in young people, young women, and particularly in a child. And we picked up a child who had this and is now an adult, and within 2 years is free of it, which is pretty much unheard of in anorexia. It often stays 20s, 30s, and by the end of the 30s, people begin to age out, and it can be around. But they've done amazingly well. And interestingly, watching peers of their own who've been in rehabs and not do so well. And because what happens is that when you're in your own home, in your own community, the evidence is that you learn better because it's more, it's closer to your lived reality. So the solutions that you come up with are much more in tune with your actual lived life. And the evidence is this, is that if you do have any slips or relapses, they're less intense and less severe and less and shorter in duration, because there isn't the big gap between the reality of the rehab and the reality of your life. So we haven't opened up that gap. Because there is no gap, there isn't so far to fall. Whereas what you can do in sort of admission type situations is, people get admitted, they stabilise, they're discharged, they go into crisis, they're admitted, they stabilise, they're discharged, they go into crisis, and you get that cycle.
All too common.
Yeah, and we call it the revolving door, and you avoid all of that. And that's not to say I don't use inpatient treatment, I really do. I mean, I really believe in it, but the model we have in the UK, which has been developed by mainstream mental health services, is to target those periods of inpatient care, to prepare for them, plan the time that you're going in and what you want from it and for how long you're going to be there, and work very closely with the teams in the hospital. And that's what we did with this particular situation. So this person has been into rehab for a week 3 times during that whole period of time, at separate occasions, through choice and as a planned admission.
Yeah.
Very clear about what they want to achieve with it, and has done fabulous. I'm going to cry again. I'm so proud of them for seeing this child and watching a child grow into an adult, a young adult, and get free of this condition, which would normally just hang around for decades, and they'd be in and out of it for decades. And so this Christmas, we're looking forward to them having their first Christmas that's just a Christmas.
And you're to thank for that. You are so busy managing a team of practitioners, working yourself. You're doing a lot of corporate work, promoting mental health there. I wonder if you can tell us a little about your self-care regime and how you look after yourself.
Right. So I'm planning to go skiing soon. So holidays are really important, and I maintain the boundaries around those holidays. And I never used to, but I do. And so I have a lot of interests and things I pursue. I'm a keen mountaineer, so I love wilderness. I go wilderness camping, and take everything I need and go away, and you can't get hold of me in the middle of somewhere beautiful. So I've set myself goals around learning new things. So this year I learned to scuba dive. I learned to ski this year, in fact. So I'm going off skiing again in a few weeks' time. So I do that, which is really important to me, to have other interests and other goals and other things. Otherwise I become very, very dull. I have a great group of people around me, colleagues and friends, and also fellows in recovery, who are very precious and important to me. And I'm, very honest about what's going on for me with all those people. I can be very vulnerable. And just the other day, I was sharing with the team, my team, how grateful I was for them and how difficult things have been for me the last few months. I had an ending of a relationship a few months ago. So there hasn't been much joy, but there's been a lot of support and love from people. And just being open to that, I think, is really, really crucial. I'm sort of quite, because I've had a long history of mental health problems, so I come in and out of mental illness myself, inevitably. You don't survive all that trauma, and you don't survive all that alcoholism with no cost. I have very clear mental health action plans with myself. So I have lists of things. So I have lists of symptoms that if they start to happen, I have actions that I take from it. And stress is one of them, because stress, as you know, is the core of all mental health breakdown. If you get stressed out too much, if you've got any condition whatsoever, underlying condition, put lots of stress in there and you'll see that condition emerge. That's just a simple fact. So I'm very, very careful about stress. So I know exactly what it looks like and feels for me. And if it starts to emerge, and it was a few weeks ago, I was beginning to notice I'm feeling fed up at work and a bit depressed, and beginnings of stress at work. And I just sort of knocked it on the head, and I started talking to people, and I slowed down a little bit. I looked after myself. I planned my next holiday, etc., etc. And I have ongoing supervision. So I have a professional that I see every week, and who knows me very, very well and can be very honest with me. I go to these peer groups myself because they're very helpful. In fact, I was at one earlier today with a friend who was celebrating 4 years in recovery. So that's partly why I was so busy. I had to run over to see them, but it was a nice busy, that bit of it. And I go to the gym. I try to be thoughtful about my food. I've got to lose some weight because I've had a sugar relapse, so I've got to get back on to sorting that out. But that's okay. I can sort of
nice self-compassion there.
All of that sort of stuff. And I also have a lovely home that I invest in because that's really important to me. So all those things.
That's your self-care package.
That's it.
What's on the horizons for you? What are you looking forward to working on next, or using your time?
Yeah, I mean, I sort of, as I said, before we started, so the last 2 years has been developing my model, and so developing this care plan approach with a multidisciplinary team, with assertive outreach and with stepped care. That's the model. Applying it.
And stepped care is like a tiered approach, it's so the more serious, the more intensive the level of treatment becomes.
It's also a principle that you find the lowest tier possible for somebody. You don't go in at the top tier. Because
so it could be self-directed reading or
absolutely.
Guided self-help, ECBT.
Absolutely. And you pitch it at that point, and then you can go up and down the steps with people. And so what it means is with utilising that approach, I can, if somebody has been in hospital or rehab, I can meet them at that step and then bring them down bit by bit, rather than what does tend to happen is they come out and boom, that's what happens. So we meet them there, and then we reduce services as we go along, which is why I'm particularly busy. I've just had somebody join us who's been in residential treatment. And so we are replicating that model by meeting them 7 days a week, and we'll bring it down over a period of time so there's less of a shock to the system, less chance of a relapse because of it. So we've been practicing that model. I've been recruiting the first team. So the plan is to widen now the teams, so that I have more teams being built and more professionals coming on board. It takes a long time to bring people on board because I'm looking for a particular type of approach from people. So I need all professionals to be open to this systems approach, to understanding their place in somebody's dysfunction, being thoughtful about their own practice, all the stuff we do as psychotherapists. So I'm demanding that of everybody. Whether they're a cleaner or a physio or a psychotherapist, we're all sort of having to be part of that. So that's exciting, looking at that growth. We're just about to do a campaign to bring in new patients, which is going to be asking people who may have been washed through that system I described of stabilisation, discharge, crisis, admission, who may want to try it a different way, and we've got a different way to offer them. So we're going to have be promoting the work in that sense. And we've just started the move into the corporate sphere.
Tell us a little more about that.
I'm very excited by that. I think there's a big move now, and it's all part of what I believe in, which is to provide services where people are, and that's happening more and more in the workplace now. Fits exactly with all the work I've done the whole of my career, which has been moving people out of institutions and into the community and into their own jobs, and then finding services to support people even with very serious conditions so that they can have a very fulfilling life. So I got involved in a thing called This Can Happen, which is a great conference set up by Johnny Benjamin and his sidekick. They'll kill me, I can't remember, but there you go. And Zoe. They've set up this amazing thing to bring together a best practice in sort of mental health workplace stuff. And so I got involved in the awards that we're giving out this year, and they asked me to be a judge, which was a great honour, and giving out awards for best practice in mental health work. And the great thing about it, the exciting thing is it's mental health, it's not wellbeing, and the two are not the same. And I'm not having a go at wellbeing at all, but putting on a mindfulness course at lunchtime isn't mental health specific work. And there was one project in particular that I'm going to say who they are. They're called Wave, amazing project. They're going to come on my show. A brand new startup, but they've been doing things supporting people with psychosis and personality disorders in their workforce to stay in at work and provide support to them so they can be highly valued members of the team. And that is absolutely right. That's absolutely right in terms of, on all sorts of levels, in terms of treatment outcomes, but also in terms of improvements in team and functioning within teams. So we think about things like, I won't go too much into this because I could get on a soapbox, but there's a thing called asset-based development. So the easiest way to think about it is this, that you've got, say, 6 or 7 houses in a row, 2 or 3 of them, there's high levels of dysfunction. Now, what you could do is take that dysfunction away and treat it, and those people move off somewhere else. But then there's no benefit to anybody else left. But what you can do in an asset-based model is you treat somebody there, they transform in situ, and that has a virtuous circle or knock-on impact on everybody else. And you get an improvement. And that's what you get in workplaces. And you reduce stress levels, you have a knock-on impact. People see their colleague transform. It's very inspirational. Any problems they have, they become much more confident about talking about them and seeking help before they go into crisis, because they start to believe in you as an employer. They then get to understand that the employer cares. People who feel cared for are much more effective at work than people who are not cared for, and you create a culture in which people can grow, support and develop. And you also do this thing which I think is really important, which is you have this diverse, neurologically diverse group of people, and the more neurologically diverse group of people, the more effective you are as a human being.
Absolutely.
And all the other stuff that we really like about the brain, mathematics, creativity, all of that is an accidental byproduct of what you and I are doing right now. Sort of things that we value, like technology and productivity, is accidental from the fact that you and I are relating. And the more complex and the more diverse those relationships, the more space we have in the rest of our frontal lobes, and the more productive we become as human beings.
And I share your enthusiasm for diversity and also for promoting mental health in the workplace. So keep up the great work, and all the best for the This Can Happen show. We're also going to be there.
Great.
And just to let us know where people can find you and access services, and also your radio show.
Yeah, so my website is www.noelmcdermott.net. That's very easy, or you can call me. I'll give you my mobile. It's 07506 319 745. Give me a call, I'll have a chat. And the website for the radio show is mensradiostation.com. So, but you can find it on Facebook as well, and you'll find me on Facebook everywhere, and usually by my name, Noel McDermott, rather than the company names. So if you Google Noel McDermott, you're going to find me, unfortunately.
It's been brilliant talking to you, Noel. Thank you so much for joining us and sharing your story and your work.
Thanks very much. It's been lovely to be here.
HarleyTherapy.com is here to help you book counselling with qualified professional therapists online or in person at the times and prices that suit you wherever you are worldwide. If this is your first listen to Therapy Lab, do hit subscribe to keep up to date with new episodes. We'll see you next time.